High blood pressure is super common, but figuring out the right treatment, that can feel like trying to solve a giant, confusing puzzle. There are so many options. So, how do you find the one that's just right for you? Well, that's what we're going to do today. We're going to follow one patient's story and break it all down.
And honestly, looking at all these pills, it can be a bit much, right? They're all trying to do the same thing, lower your blood pressure, but they take completely different roads to get there, and that's the key. It's not just about finding a pill that lowers the number. It's about finding the one that works with your body without causing a bunch of annoying side effects.
So to really get a handle on this, we're going to walk through a real-world type of scenario. This way, you'll see not just what these drugs do, but you'll get the inside scoop on why a doctor might pick one over another for a specific person.
All right, let's meet our patient. She's 56 years old, and she's just been diagnosed with two new things: hypertension, that's high blood pressure, and type 2 diabetes. But here's a really important piece of her medical puzzle. She's had asthma for a long time. So her doctor starts her on a very common medication, lisinopril. Now remember those three things: diabetes, asthma, high blood pressure. They are all going to be major players in this story.
Okay, before we even talk about the drug, we gotta understand its target. And for a lot of these blood pressure meds, that target is a really powerful system in your body called the renin-angiotensin-aldosterone system. Yeah, it's a mouthful, so we'll just call it RAAS. Think of it like your body's own internal thermostat for blood pressure.
Now, when this RAS system kicks into overdrive, it sets off this whole chain reaction, kind of like dominoes falling. It all starts in the kidneys, which release something called renin. That helps create a powerful chemical called angiotensin-2. And angiotensin-2 is a double whammy. First, it squeezes your blood vessels tight, and second, it tells your body to hang on to more salt and water. So you've got tighter pipes and more liquid flowing through them. Yep, that is the perfect recipe for high blood pressure. And that brings us right back to our patient's first prescription, lisinopril. This drug is part of a big family of medications called ACE inhibitors. So how does an ACE inhibitor actually work? Well, if you think of that RAS system as a factory assembly line that's churning out angiotensin-2, an ACE inhibitor is like someone walking over and just shutting down one key machine. It blocks the enzyme, that's the ACE part, that makes angiotensin-2. So if you can't make angiotensin-2, your blood vessels don't get squeezed, you don't hold on to extra fluid, and voila, the assembly line grinds to a halt and your blood pressure starts to come down.
And you know what? For our patient, it's working. Her blood pressure looks great. But there's a catch. A new problem pops up. This dry, nagging cough that just will not go away. And this becomes the central issue we need to solve in our treatment.
So what's with this cough? This isn't just some random, unlucky side effect. Nope, it's directly tied to how the medication works. So, what's the little chemical troublemaker behind it?
The culprit's name is bradykinin. It turns out that the same ACE enzyme that builds up angiotensin-2 also has another job, breaking down bradykinin. So when you block that enzyme with the medication, your bradykinin levels start to climb. Now this is actually partly good. It helps your blood vessels relax. But in your lungs, that extra bradykinin can be really irritating, and that's what leads to that classic telltale ACE inhibitor cough.
All right, that cough is just not working for her. It's a deal breaker. So her doctor needs a plan B. And this is where our next class of medications makes its entrance, the ARBs.
ARBs, that stands for angiotensin-2 receptor blockers. They work on the very same RAS system, but they jump in at a different point in the process. Instead of stopping the factory from making angiotensin-2, they just let it be made. But, and this is the clever part, they stop it from doing its job. Think of it this way. Angiotensin-2 is a key, and it's trying to fit into a keyhole, or a receptor, to raise blood pressure. An ARB comes along and plugs that keyhole. The key is still there, but it can't get in, so the door to high blood pressure stays locked. And that right there is the key difference. It's pretty brilliant. The ACE inhibitor stops production and messes with bradykinin, which can lead to a cough. The ARB, on the other hand, just blocks the action at the very last step, and, crucially, it leaves bradykinin totally alone. So what's the result? You get the blood pressure benefit, but with no cough. So for our patient, the solution is crystal clear. By switching her over to an ARB, she gets that same awesome blood pressure lowering effect because it's still targeting that same RAS pathway, but she gets to ditch that annoying cough. Pretty neat, right? Problem solved.
But hang on. Let's throw a wrench in the works here. A patient's entire medical history really drives these decisions. So what if our patient's story was a little different? What if instead of asthma, she'd had a heart attack in the past? Well, that would open up a whole new set of options and bring another major class of medications into the conversation.
And that brings us to our next group, beta blockers. Let's take a look at how these guys work and where they fit into this whole puzzle.
Now, beta blockers play a completely different game. They don't target that RAS system at all. Instead, their job is to block the effects of adrenaline on the heart. It's kind of like putting a governor on an engine. It tells the heart to just chill out a bit. It slows the heart rate down, eases up on how hard it pumps, and that reduces the heart's overall workload and its need for oxygen. You can see why that would be a huge help for someone who's had a heart attack.
Okay, but here's where it gets really interesting, and it's a super important detail. There are different kinds of beta receptors in your body. Beta 1 receptors, those are mostly in the heart. But beta 2 receptors, they're hanging out in the lungs. So a cardioselective beta blocker mostly just targets the heart, the beta 1s. That makes it much safer for someone with a lung condition like asthma. But a non-selective beta blocker, it hits both the heart and the lungs. For our original patient with asthma, that could be really dangerous. It could actually trigger an asthma attack. And that is why her history of asthma was such a critical piece of information right from the very beginning.
So you can start to see how a clear logic begins to form here, right? ACE inhibitors and ARBs, they're fantastic choices, especially for people who also have diabetes or kidney disease because they actually help protect those organs. Beta blockers, on the other hand, are often a go-to first-line choice for patients who've had a heart attack or have certain kinds of heart failure.
We can actually lay this out like a simple decision tree. So, step 1, a patient has high blood pressure. Step 2, do they also have diabetes or kidney disease? If yes, you're probably leaning towards an ACE inhibitor or an ARB. Step 3, do they have a history of a heart attack or heart failure? If yes, a beta blocker is a really strong consideration. But then step 4, do they have asthma? If that's a yes, that's a huge caution flag. You'd want to be super careful, maybe use a cardioselective beta blocker, and definitely avoid the non-selective ones. You see, it's all about customizing the treatment to fit the person, not the other way around.
All right, so picking the right drug is just step 1. The journey doesn't end there. Using these medications safely means you have to be on the lookout for potential side effects, and that requires some careful monitoring.
So, when you first start one of these medications, it's pretty normal to feel a little dizzy or maybe more tired than usual. That's just your body getting used to a new, lower blood pressure. But it's also really important to watch for more serious stuff. For example, both ACE inhibitors and ARBs can make your potassium levels creep up. So you'd want to watch for things like muscle weakness or cramps. And of course, you've got to keep an eye on kidney function.
And then there are the things that are absolute drop everything red flags. These are signs you need to get medical help right away. The most serious one, though thankfully it's rare, for an ACE inhibitor is something called angioedema. This is a scary, rapid swelling of your lips, tongue, or face that can actually block your airway. Any sign of that, or feeling extremely dizzy like you might faint, having a very, very slow pulse, or suddenly getting much more short of breath, those are all emergencies.
So, it all comes back to this one question. Is your blood pressure medication the perfect fit for you? The big takeaway here is that finding the right treatment isn't just about chasing a number on a blood pressure machine. It's about looking at your entire health story. So the next time you talk with your doctor, don't be shy. Ask them, is this really the best option for me? Because ultimately, being an engaged, active participant in your own healthcare, well, that's the most powerful tool you've got.